In this video, we'll discuss hyperfunctioning solitary nodule or toxic adenoma. In toxic adenoma, TSH is low. Why? Because of hyperfunctioning autonomous nodule. How about radioactive iodine uptake in the heart nodule? The radioactive iodine uptake is increased in toxic adenoma. What's the cause of toxic adenoma? Most patients have mutation in TSH receptor. There is activation of the TSH receptor. Activating TSH receptor mutation occurs in more than 90% of cases. This activating mutation leads to increased activity, increased adenylate cyclase, and cyclic AMP activity leads to increased thyroid follicle cell proliferation and function. How about thyrotoxicosis? Thyrotoxicosis in toxic adenoma is usually mild without hyperfunctioning features of grave disease. How definite diagnosis is done? It's done by thyroid scan. Radioiodine uptake. What's the difference in radioiodine uptake in hyperfunctioning nodule and a normal thyroid gland? There is an increase in radioactive iodine uptake in hyperfunctioning nodule and a decrease in radioiodine uptake in remaining of the normal gland. Normal thyroid gland function is suppressed in this condition. Because of increased radioiodine uptake, FNA biopsy is unnecessary in toxic adenoma. Whereas the second step in evaluation of cold nodule after radioiodine uptake is FNA biopsy. So what's the treatment of toxic adenoma? Treatment with drug, anti-thyroid drugs and beta blockers, but they are symptomatic treatment. The other treatments are radioiodine ablation, surgery and ethanol injection. Treatment of choice is radioiodine ablation. Iodine 131 is concentrated in the hyperfunctioning nodule but doesn't damage the normal thyroid tissue. And disadvantage of this radioiodine treatment is that hypothyroidism occur in less than 10% of cases in 5 years. And how about surgery? Two options: enucleation of the adenoma or lobectomy. And third treatment is repeated ethanol injections under ultrasound guidance ablates hyperfunctioning nodule.